Wow, that was quite the introduction. Um, Welcome, everybody. I hope you appreciated the little music interlude as much as I did. So we're very pleased to welcome you in this workshop. I think I might just start and share my screen right away. Here we go. So today we are going to talk about communication skill training and discussing a little bit about learning, teaching how to have difficult conversation virtually. And we thought about this workshop obviously inspired by this COVID pandemic, where more virtual conversation with patients and family became necessary, and also during which there was a huge shift towards virtual teaching. So it became clear that we needed to adjust a little bit our communication skill training, and that obviously included simulation-based training. What we noticed as we were preparing for this workshop is that although there is an emerging body of literature on the topic, there's still no hardcore evidence of how to best do that. So, however, most of us have had experiences, positive or not, over the last 18 and 20 months. And this workshop is very meant to be an opportunity to share those experiences, to discuss our reflection on those, and not so much about us providing you with ready to apply solutions. So please feel very free to participate, interrupt us, and add notes in the chat box that we'll monitor throughout, and engage in the little activities that we've prepared so that we really get all the wisdom from this group and that we make this workshop as productive as possible. So I'll just say a brief word about ourselves. So just so you know from where we're coming from. So I'm Dominique Piquet. I'm actually an adult intensivist. So I certainly have an interest in medical education research and in simulation-based training and simulation-based education. But I am not I don't have any knowledge about kids actually. So hopefully that will still be relevant. To facilitate this workshop with me today, we have three of our colleagues. So we have Catherine, who's one of the pediatric intensivist trainee at fellow actually at the Kids in Toronto in Canada. We have Brizeda Mema, who's a staff pediatric intensivist at the Kids in Toronto, Canada. And we also had Anne, who's one of our colleagues, who's actually bring a very different and complementary expertise in developmental in child development in the pediatrics, obviously, and also had focus or research and teaching activities on communication skill training. So that is our team. It would be as kind of general rule, not rules, but of engagement, if so we have a pretty large number of participants, but if possible and you feel comfortable, would be important or easier for us maybe to be on camera, especially during the interactive part, and there will be many of the sessions. And as I said, feel free to use the chat box or raise your hand virtually if you have any comments or questions throughout the sessions. Some of us will monitor that. So just a word to say that we don't have any conflict of interest relevant, and a summary of the outline. You may or may have not looked at the objective of the sessions, but essentially our goal today is to discuss a little bit about virtual communication with patients and families, how they're similar and different from in-person communication, and discuss the implication of that for education. We also want to look more specifically at learning communication skills in a virtual environment, and discuss the potential challenges in strategies related to virtual teaching for that purpose. And finally, we'll do a third shorter sections on thinking a little bit about how to integrate virtual and in-person, as well as simulation and real clinical environment teaching and training for communication skill development. So as I just said, we thought we would first initially focus a little bit on the differences between virtual and in-person interactions and communication, because obviously that's the kind of clinical activities that we want our trainees our colleagues to learn, but also because a lot of the concepts that apply to the differences that apply to in-person versus virtual communication with families and patients also apply to differences between in-person and virtual education. So, we would just like you to, we will ask you in a minute to share a little bit your experience about virtual communication with patients and family for those of you who are clinicians. Maybe I'll ask Catherine to share what has been her experience during the COVID pandemic of having to discuss virtually or on the phone with parents and families of young or less than young patients. So Catherine, would you like to just maybe share a little bit your own experience as the rest of the participants think a bit about their own experience and how this was a bit different than their previous in-person communication?
Yeah. Yes. So actually, I'll share one short story that kind of made me reflect about the limitation of virtual communication for one of the first time, and that made me start to think about ways that I could use to overcome them. So last spring, while the ICUs, the adult ICUs in the province of Ontario were like overwhelmed with COVID-19, you may or may not know that the Sick Kids Hospital where Brizada and I work had to care for almost 40 adults with COVID. Patients would be first admitted to an adult facility, and they would then be transferred to us when the need arose. And one day I received a critically ill young man that was on ECMO at that time. And he had been progressively deteriorating over the last day, and he even had a cardiac arrest shortly after transfer, but was resuscitated. And I very vividly remember when I first called the wife to update her about the eventful transfer. And when I first asked her what she understood about the situation on the phone, she was calm and almost dismissive. Her brother was behind and the rest of the family too. And she was confident, telling me that, well, everything was stable. He was just slowly recovering on ECMO, that machine. And I was just shocked, and I had to kind of wrap my thoughts around rapidly to decide where to start to explain her where things were. And it made me realize that most families, despite updates and our best intentions, they didn't have a good sense of how sick their loved ones were. Like, how can you ask them to truly image coma or pain or their pale skin, lines, machines all over the place? So this is my story and where my reflection started.
That's great. Thank you so much. So anybody else amongst the audience would like to share a little bit or reflect on their experience, especially within I would say during the last few months, on the kind of interactions that they had with patients' family on the phone or virtually on Zoom or other type of software, and what kind of challenges or opportunities those have presented for them. You can either add it to the chat box or raise your hand virtually or unmute yourself if you feel comfortable to do so.
Yeah, so I'm Dr. Zainab Sali from Indiana. I work in the NICU, and we are a referral center, so many patients come from the long distances. They are referred, and it's a challenge for the parents, and it's hard for them to understand, especially if they need to talk to multiple people, like physicians. They usually talk to the bedside nurse pretty often. They talk to nurse practitioners and sometimes with us, and we each give a different perspective, I believe, from our own, what we see, how the baby is doing. And this makes them really confused, frustrated. One person may say, oh, your baby is doing great, or maybe baby is doing fine. What she or he means is that his vital signs are okay now, or maybe compared to yesterday, they are stable, but it doesn't mean baby is totally fine. At the same time, we don't know what the parents really want to know sometimes. We don't ask them what they want to know sometimes. We just tell them what we see that is important to them, but we have to maybe, that's what is important for them. It's really tough when talking over the phone. You don't know, you don't get the visual feedback from the parents.
Yeah, well, thank you so much for sharing. And did you say you were, where did you say you were joining us from?
In Indianapolis, Indiana.
Indianapolis. I thought India, and I thought, wow, that's that's very far away. So, but that's interesting. So, did you think that the difference of perspective from the different healthcare professionals, did you think that that problem was a bit exacerbated by the fact that people could not necessarily be there in person? Because that's certainly also a problem we've at least experienced in my site or others, even at times pre-COVID, where sometimes the nurse at the bedside would provide some feedback, and then when we would meet with the family at another time, there was some divergences there. Yeah. So I don't know, did you feel it was worse during it's been worse with the
it's interesting, because if it's a mother, for example, who comes pretty often, and then for example, for some reason she cannot come a few days, then I think she compares her experiences when she was there, and sometimes this makes it harder because she knows what it means when she was there, and when she wasn't there, she gets upset because she says, I know my son, although he's a baby, he likes that, and what you're telling me doesn't really match what I saw 3 days ago. You're right. It's so hard to communicate tough news, especially while we're on the phone, and being not there, of course, really makes it harder.
Yeah, absolutely. Well, thank you for that, and thank you, Adil, for also sharing your experience as a emerge physician in Pakistan. So now I'm getting right. I got that right. It is actually Pakistan, quite far, quite far from us in Canada, that also have experienced a similar thing. Anybody else who would like to share their views or their experiences?
Hi, I'm Diana.
Hi, Diana.
Hi, everyone. I'm a pediatric trainee and also recently a simulation fellow in neonates. So I agree with everything that's just been said. I think another challenge, particularly in development clinics, is also you don't have, I know we're talking about communication with families, but also with the children that come in, it's really difficult to build that rapport. You can't really do that over the phone. And so obviously it limits very much what you can achieve in a telephone consultation. I just feel like it's really difficult to carry out any sort of meaningful assessment, and you lose a lot by not having that interaction with the patients, even if they're quite little. So I noticed that was a big challenge for me when I was doing some development clinics over the phone.
Right, and another developmental physician. So thank you for joining. I'm sure Anne is happy to see colleagues on the line.
For sure. Yeah,
For
it
sure.
has been really challenging, right, to do developmental assessments virtually, because especially if you're on the telephone, you have no sense of what that child is really like. And we rely so much on that rapport building and informal observation. So absolutely, Diana, I totally agree. It's been really challenging with that information that we rely on so heavily.
Perfect. So I think we have a few important points that came up during that conversation. So these are just some of the things that you might have experiences in terms of differences between in-person and virtual communication. We may have missed some, but these are things that came across in our previous discussion and in the literature. So in-person meetings, obviously, I've said, rely on verbal and nonverbal communications. There are some interruptions that can happen, but they're often of different natures than virtual conversation. People tend to focus maybe more naturally both on facts and information exchanges as well as emotion. And families especially have cues from previous visits when they spend a lot of time at the bedside and often have some even subconsciously some notion of what's happening, and those cues are often not present. So and when you have an in-person meeting, you also have certain control of the physical environment. I say control because I mean in the context where we work, often like in the ICU where I work, it's not a full control, but at least we can go in a separate room and everybody is there at the same time. In a virtual setup, you also obviously very importantly rely on verbal communication. The view of the person is quite limited often. There are often some technical challenges with the communication that can sometimes interrupt it or delay, involve some delays in the communication. There's also a tendency, and that's been shown in the literature, for healthcare professionals to focus more on facts and less so on emotional support. Families sometimes are a bit more, clueless about what's going on with the patient because they haven't had those previous contact and direct, bedside kind of understanding of what's happening. And obviously the physical environment where the family will take the meeting from is not necessarily directly in your control and cause sometimes some problem in terms of noise and other issues that can happen. So when we were discussing the workshop, we were thinking that it's important when we talk about communication skill training to actually consider all aspects of educations, and not only the competency or the domains that get often addressed when we talk about communication skill training, but also all the components that come into play to realize really what are the implications of having those conversations virtually and also to teach those virtually. So obviously we've talked a lot already about exchanging information, being consistent in the message. You'll see a lot in the literature that I'm sure a lot of you are familiar with about communication skill training, existing frameworks that have been actually published on, and some of them have been studied a little bit. And certainly we've used some in teaching communication skills and adapting a kind of guide or with some certain kind of steps that trainees can learn to use to structure a little bit those conversations. There's been also a lot of focus on responding to emotions and managing your own emotions during those discussions. And that's an aspect that we're going to discuss a fair bit during this workshop, because often we feel that virtually this might be a bit more challenging to do. We talked about the setting, the physical environment, the context in which those discussions happen, but there's also other very important aspects like the cultural diversity, which may have implication also for virtual communication, and certain legal and ethical aspects of the discussion. For example, issues of confidentiality with virtual communication, people recording certain discussion might actually be, comes up as specific issues with virtual communications. So because virtual communication is a little bit different from in-person communication, there are certain skills, therefore, that might need to be more specifically thought of in that context, and therefore develop amongst our learners, so that in the future, when they have to hold some of those conversations virtually, they have the skills necessary to do so. And that might be, as Catherine was pointing out, using more effectively verbal communication to either carry convey informations that have not been grasped by the family being far away from the bedside, or also to be very explicit about emotion that cannot be necessarily expressed as well in a nonverbal manner. Also planning communication setting on both ends of the conversation and making sure that the person at the other end, the receiving end, is actually in a setting where they can actually pay full attention to this conversation, and considering issues of confidentiality. So I was speaking a little bit earlier about some frameworks that we've used, and I'm sure many of you are familiar with those to teach communication skills. So the spikes is probably one that have been used pretty broadly in different contexts. And you can see that some of those steps, such as the setup, needs a bit of a different type of preparation in a virtual environment, right? And can need a little bit more actually a time to get those things prepared. And I really like what one of our participants mentioned about. So we talked about perception and making sure that we know exactly where people are, and that might be quite different if the conversation happened virtually and the patient, the family haven't been too much at the bedside. So not assuming that people know or understand the meaning of what we say, but being more descriptive about it. Inviting, so that's that one referred to the comment of one of our participants saying, well, we're not even sure actually what they want to know. And I think so that's a specific step that is recommended in that framework. And I think sometimes something we might skip more easily virtually because we just want to deliver the information, but it might be important to actually think about asking specifically and explicitly, but they want to know first, and the emotion. So we talked about that. However, there are other frameworks, and just again, many of you might be very familiar with this, but if people are not, I think Vital Talks is one of those group that have developed actually very useful resources for communication skills teaching and training, and has tons of resources available on their website, and that are free for everyone in addition to specific courses. But their focus is very much on emotional support, and this is just an example of the resources that they provide. So those nurse statements that can be used to articulate empathy and can be practiced. And if you look at the nature of these tools, they are actually absolutely applicable in a virtual context. And those are examples. And there are many others that we're just providing here for your information that are available that actually can really help both mastering and teaching communication skills that are very relevant to the virtual context too. So so we try to summarize a little bit what are the differences and the similarities between virtual and in-person communication, but obviously that needs to lead to, well, what are the ways that we can teach those communication skill strategy both for virtual and in-person encounter, using virtual technology, which has been very much our reality over the last 18 months. So I'll just pass on the microphone to the virtual microphone, I guess, to Catherine, who will actually discuss that next section. Sorry.
Thank you, Dominique. So let's now talk about the challenges of teaching communication skills virtually. First, people may have difficulty to focus on the teaching session or, be doing other things. Second, physical distance and a screen can make people more emotionally detached from their colleagues and from the scenarios or patients that are in front of them, for example, as we discussed before. And third, some experts consider that virtual teaching allows for people to express themselves more freely and to participate more easily, and that it fosters psychological safety, but that is not believed by all. So saying this, we'll go to our next activity. So we will divide you in small numerated groups and send you in breakout rooms for 5 minutes. Each group will be assigned to one objective, A, B, or C, and we'll have to think about 2-3 strategies to reach these objectives that speak about the challenges we just spoke about. So if I read them, you have to think about 2-3 strategies to ensure that your learners, as you are planning a simulation-based virtual teaching session on communication, so 2-3 strategies to engage cognitively with the educational material, or engage emotionally during the session, or that they feel safe in your learning environment. So we'll have 5 minutes to discuss that. And Briseida, me, and Dominic and Anna will all be in each of the 4 groups to answer your questions if needed. And we'll post the question in the chat.
And something, Catherine, is that every group should work only on one of them, not on. Okay.
So let's say that group 1 will do A, because we didn't know initially how many people there was going to be. So group 1 will take A, group 2 will take B, group 3 will take C, and group 4 will take A again. See you later.
And Briseida and others, you may have to remind your group which one they have to pick.
Dominique, I think they're in their groups. Hi, if you're just joining us, we just went into breakout sessions. You should have been prompted to join a session. If you were not, feel free to turn on your camera and I can help you get there. Those of you that are still with me in this room, if you need any support in getting to your breakout sessions, please let me know. Hi, Monica. Can you hear me? Monica, are you able to hear me?
Oh, yes.
Okay, I'm just gonna pop into a room really quick and there are people still entering, so just give me 1 minute.
Okay.
Actually, let me make you a co-host just in case.
It's a big old event.
Hi, Monica, I'm back.
Perfect.
They just hadn't let me know how long they wanted those to go. So
Oh, there you go.
I had to make sure, and there's still people entering. So thanks, we're good.
Yeah. Okay, cool. Holler if you need anything else.
Sounds good.
All right.
We are back, Dominic.
Yeah, I was just waiting, but I think most group are back. Brizetta, would you like to? I know we're not necessarily going in order, but I'm sure people tired of hearing my voice. So maybe would you like to summarize a little bit what was discussed in your group, and maybe which kind of challenges you were discussing?
Yes, I can summarize the group discussion. So I was in group 3 and was like things to mitigate, like how would psychological safety change from, an in-person simulation scenario to virtual. And there were a couple of ideas. One of them was like a thorough pre-brief about setting ground rules, just like in any other simulation setting, and adding a few extra cautions here about how people use the chat or how they give feedback, or and especially being in private area and not recording, but also a balance that we don't make the pre-brief so exhausted that people are bored already of the session, because the simulation is supposed to be interactive. One was the other one was the part of the pre-brief is that, simulation is one of those instructional design that while you teach, you assess at the same time, because people perform, and being frank about that we are somehow evaluating, but being supportive as well. And in terms of the debrief, that following the same principles as a debrief in person, but then you're losing some of those nonverbal cues that participant might have during a in-person debrief. So that was the discussion, very rich discussions.
Thank you. Anne, would you like to summarize a little bit your discussion?
Sure. So I was in group 4. We tackled the first one, which was cognitive engagement. And I would say our group had a number of really practical strategies for looking at that. I'd kind of categorize them in 2 areas. One is to think a little bit about the learning environment, and then the second is to try to increase interactivity. So in terms of setting up that positive learning environment, getting to know each one of the people in the room, like an icebreaker activity, for example, seemed to be a good way of doing that. And then also establishing some ground rules around sort of what the expectations are, and that it is a safe space, that they want everyone to participate. And then in terms of increasing interactivity, they came up with a number of good ideas around trying to get a sense of that comprehension, because you don't necessarily have that feedback right away, the nodding or the ahas or that kind of thing. Asking them, what do they understand from that situation, because it's communication, right? What's your understanding of that? Or to do like a teach back, tell me what you, teach me what I've sort of shared with you. And then the other area is to make it personal. So share your own personal experiences. We talked about using videos, both like exemplars, as well as maybe things that could be improved in terms of communication, and actually doing video recordings. That's the nice thing about Zoom, is you can easily video record people doing a simulated or a role play communication interaction, and then getting some feedback on that. So some really great ideas.
Great. So I might just add briefly to that, because I was in group 1, and we also discussed the same kind of challenges about how to engage the learner, and a lot of the same things were discussed in my group. So obviously we had a word about different tools that are available to ask, like survey the participants and force them to engage, and Mentimeter was kind of suggested as one of the tools that has been used by a fair number of participants, and also maybe, which I think is an interesting strategy, just put I'm not going to move this session forward until 80% or 90% of people have actually participated in the Mentimeter, to try to, again, add some incentive for people to participate. And there was also things about icebreaker and pre-briefing and pre-briefing. And the other discussion that two more points that were made. One was about so using also the debriefing part to make sure that people engage in that part and asking people who are not necessarily on the spot to actually join in at that time. So and also we had a bit of a chat about the specific challenges of having mixed modalities within the same session. So having people who are in person and having people who are actually present virtually. So that kind of hybrid model that actually posits on challenges where people online often feel a bit somehow penalized or half excluded because they're not necessarily present on site. So that was the flavor of our discussion. Catherine, can you tell us a little bit what your group discussed?
Yes, so my group talked about how to help with the emotion sharing. So one of the also many very concrete examples. So first, the use of personal storytelling, a little bit like I did to start and as others did to start. Thanks again for sharing, kind of as an icebreaker to because when you share true things, it triggers or bring true emotion from other participants more easily. People rely more easily on that. The other thing was that to share true stories, it helps, it makes you more vulnerable. And again, we were kind of reconnecting with emotional, psychological safety. And we were saying that if you foster psychological safety, well, it's also going to encourage people to truly share their emotions. So making connections there. The other thing that one of our participants was saying is that it's a simulation conference. So if you have simulation with very good standardized patient, as we had talked before, it can trigger true emotions. Like when you watch a movie, some people, it will trigger emotion. They will cry because it's so realistic, and in others, it's not going to work. But for some, it really is. And having actors that are very into their role and very attentive to the scenario and adaptable makes it also more realistic. And the last thing is to have a facilitator to introduce scenarios was felt to be helpful, and to try to avoid breaks during scenario to make it more realistic was another thing.
That's great. Sorry. One thing is also to unmute yourself when you're about to speak. You would think that after a year and a half of virtual thing, we would have learned that, but still a common mistake. So we thought we would maybe spend briefly a bit of time on each of those aspects. Yes. And Catherine, so would you like to start with cognitive and while you're bringing up your slides, I was just asking the audience which movie made them cry. And,
do you want me to share the slide, or are you going to put them?
Oh no, yeah, sorry. I'm the one who's supposed to do that. Thank you. Oops. Thank you for reminding me of that. I will do that in a second. Okay, here you go.
I don't know how it's called in English. The wish list. I cry every time.
Okay.
Okay, perfect. So let's talk in details about each of these three perceived challenges. I'll start talking about the first 1.5, and Preseda will continue. So first, this is the cognitive and educational presence. This is a challenge that we all experience, both as teachers or as learners, and it's pretty much applicable to all virtual education settings. As you know or may not know, online learning has existed for at least 20 years now. It's not new it's not a new COVID era thing, but it has now reached the majority of learners and teachers, as I just said. And unfortunately, or fortunately, for some other reason, it is there to stay, as mentioned by Dominique. So how do we go from this picture to the next picture? Well, it is not an insurmountable challenge, and it is possible to have everybody involved in a teaching session about communication. So, next slide. one of the key things to foster educational presence and cognitive presence is to have facilitator. It is proven in the literature that if you have facilitator present, they are really essential to adapt technology in the compassion education, rather than have learners as just autonomous learners. It's also very important to keep the focus on learners rather than on the teacher, which can seem easy, but sometimes as a teacher, we lose ourselves when we talk. And it's also in keeping with the growing field of student-centered learning. The other thing is, we know in the literature, again, that peer-led facilitation works to encourage sharing of personal stories, a bit like we said after our last workshop. And so some suggest that it could be used, peer-led facilitation, in compassion education, but this will have to be further tested and studied. As a facilitator, what can you do? Concrete example. So most of the things I'm going to say here, they are things that are also applicable to others, other educational interventions. So you can start your talk with virtual etiquette rules. You don't have to, but for example, mute yourself when you're not talking, or as Dominic said, unmute yourself when you talk. Stay present. So ask participants to stay there if they can, rather than go and do other things. Just saying it can be helpful. If you want to make it a bit more informal and foster psychological safety, you can state that it's okay if your cat passes in front of the screen, or if you have to take a break because your kid needs you. You can say it at the beginning of the talk and it's going to help. The other thing is that you don't have to be an expert, but it's good to be pretty good with technology, to be at least fluent and be able to use technology creatively to engage your learners. The other thing is that it's very useful to use video software like Zoom, as you saw, and to encourage people to keep their cameras open. And obviously, if they feel safe to do so. Because this leads to one of the most important things, which is to encourage interactivity, both between learners and between facilitator and learners. This is often limited by group size, so it's important to choose, if you can, the size of your group, smaller groups allowing more interactivity in general. Oops. To use breakout rooms if you can, so smaller groups of people can talk to each other, especially like today when we have a large group of people that cannot all talk to each other. To name trainee during interactions by their name, to make them more engaged, to use polls, for example, or encourage chatting on the side like we're doing right now. So even if you cannot speak, you're able to interact with others. And to create also thinking break. I don't know if you know what that is, but that's, for example, when you're doing a simulation and the learner that's doing the simulation or the facilitator asks people to take a pause. So the others are able to give feedback, or the learner is able to express how he is feeling during that simulation. Next slide. The other thing is to have clear objective, so people can focus on and know your audience. So you have objectives that fit with them. Provide feedback is super important too. And monitor learners' engagement. So if you see that they're kind of drifting away, cameras are closing, try to get them re-engaged again. And if it's possible, like right now we can't with the current conference, but organize some in-person interaction on the side can be nice. And all of this is to foster a sense of online community. Next slide. So my group, emotional engagement and virtual compassion. So how do we foster that? So the first thing about compassion. Compassion, let's define it first. So it implies two things, both an emotional and a behavioral response to suffering. So that's different than empathy. And you can go to the next slide, Dominic. Empathy is really limited to experiencing or realizing someone's suffering, but without the behavioral response to like try to help that person or desire to help that person. There are many reasons to encourage compassion. It seems pretty obvious, but practicing compassionate medicine is really part of professionalism. It's very well embedded in educational framework like CanMed. And it's also associated with decreased risk of error, burnout, healthcare costs, and also improving well-being. Next slide. The other thing that's important to know is that teaching empathetic communication virtually, it works. So we just talked about the nuance between compassion and empathy. Now I'm talking about empathy, but I'm using that because in most of the literature, the recent term that is used is most often empathy, and hopefully more things about compassion will appear. Often when you read text though, they look interchangeable. We expect that the literature will probably flourish in that field in the next few months to a year. And so far, it shows that virtual communication training, it improves skills, and it also seems to improve empathy. There are some challenges to implement it or to create those interventions, but we are adaptable creatures, and it's important to do it, so we will. A little thing about simulation, because it's a conference it's a conference story about simulation. So simulation can be adapted for educators to be able to overcome the obstacles of social emotional reciprocity. So one of the most important thing we can do with simulation is we can foster adaptability by using simulation in various settings like phone calls, video conferences, doing virtual in-person conversations. We can use creativity and create realistic, emotionally challenging scenarios to enhance fidelity of human interaction. And as we said, adding thinking break can be helpful also for emotion sharing. The other thing is that simulation training, it will require some adaptation of the learner's end, especially if you want to apply that after to is in-person practice. So for example, the learner will have to emphasize gesture if he wants to share his empathy. So leaning forward like he is listening more attentively. Look at the camera, where the camera is, so that the person has the impression that he's talking to him, even if he's not looking at the same spot in the screen. You'll also have to be more attentive to the facial expression of the patient he's talking to, or the tone, the speed of the voice on the phone to assess the emotional status of the person he is speaking to, because of the rest of the body language is absent or hidden, like if somebody is fidgeting, for example, or walking in the room. So for sure, these are going to be challenges. But what's amazing about these simulations that are virtual is that they are now communication pearls that, fortunately or unfortunately, we can and have to transpose in our true practice, because now we're basically almost all having to do virtual conversations. So these can be applicable in our true practice. The next slide is really only a reference slide about other educational methods for empathy-related learning, but it's really just for interested educators. And it's a bit more advanced. And the last thing I wanted to talk about was what's the role of a facilitator for this. Well, you have to be a role model and a compassionate educator yourself if you want your learners to do the same. You have to create an educational climate that encourages compassion, including fostering psychological safety. And the last thing is, when learners are practicing communication, for example, in a simulation, it's important to provide them feedback about the conversation itself and not just about if they are following the framework like Spike. So that's something important to do. So you can go ahead, Brizeda.
Okay, so barriers to emotional expression, and here we are talking about barriers to emotional expression when the simulation happens virtually rather than in person, like we are used to do. Now, throughout this workshop and throughout our conversation and discussion in the breakout room, one thing is for sure true and has come again and again is that those challenges existed there even before, and the virtual has simply accentuated some of them. And the same principle that we have used to deal with the challenges in simulation for other things can be used here, and we can adapt a few things. And I took this quote from a very good article in Medical Education that says participation in all educative simulation is an imaginative act, regardless of the degree of fidelity. And so you can read this on your own, but it just highlights that whether we do the simulation in person or we do the simulation now virtually, all those challenges were there. Next, Tom. So when we look at some of those challenges that are there in person and are a bit more attenuated virtually, is that, the suspended disbelief, the complex nature of student engagement with an imagined scenario that we're giving them, and now is virtually the simulation setting, and then the standardized participant or the simulated like patient and mannequins, whatever we are using virtually. Next one. So while there are many frameworks out there, and I'm sure many of you are very, very experienced in simulation and simulation design, I thought I'd go over one of the frameworks that helps me look at how I design a simulation scenario and what the two main things of this framework are. One is the structural properties of a simulated environment, the physical resemblance itself. But if we are teaching about how to, through simulation, how to improve virtual communication, then it makes sense that a virtual simulation session is more of a physical resemblance to, like, how this is going to happen in the real life. And the other aspect of it that is actually more important is the functional properties of simulation context. What are our learning objectives, and how do we actually align a learning objective with our simulation design? And again, here, if we're teaching about virtual communication, then again, the virtual simulation fits very well. Next, Dom. Now we spoke about, that it's the suspended disbelief. It's a big deal, but Catherine said that during her discussion about, the emotional barriers, people brought up that, and then there is a big list of movies that the participants have written in terms of what makes them cry. And we do know that there are actors, and we do know that that is not true, but we still cry. And so there is a great performance. Yes, a great performance can make someone relate and can make someone shift that perspective and think about. And there's plenty of data how, watching movies or, watching documentaries or even reading narratives will provide or elicit an emotional response that sometimes can be even more powerful than when you deal with a patient. So it is possible to design a simulation scenario to bring up emotional responses from the participant. Next, Dominic. So when we go back to the flower that Dominic brought up at the beginning, is what are elements of, and we did choose this framework, and I'm sure there are many other frameworks in terms of what constitute the communication with the family. It's which one of those elements of the communication are affected by, in-person versus virtual communication with the family, and which one are affected by us being able to do a simulation session in person versus virtually, and what can we do to actually mitigate some of those barriers and challenges, and especially integrate them together. So at the end of the day, is about what mode of communication are you targeted? Are you trying to teach in person or virtual simulation, and virtual with video or with no video? Which elements of this flower are you going to target with simulation? How will you target different aspects, emotional expression, and how do you integrate them together? So these are some of the principles. Next, Dom. And so I also thought of bringing up this article in Academic Medicine, that medicine, machines, and medical education. And you can read the quote, but the thing is that even despite the digitalization, despite the virtual care, despite everything, it looks like the role of a clinician is going to be the centrality of the humanistic interface with patients, such as the doctor-patient relationship, is paramount in the complex medical world of machine and social media. So that humanistic aspect of medicine is the one that is going to remain. And how do we keep that in a virtual, digitalized world? And this is article published in JAMA, and they spoke about some of the strategies that you can do when you are in nonverbal communication to accommodate the limitation when you have in audio or video, what emotional cues of the patient you might be obscured, and how do you try to mitigate those obstacles that are given to you in a virtual environment, and these can be used during the virtual simulation training. Next one. I also thought, like, Dom gave some resources at the beginning, but there are plenty of resources out there, and is the Academy of Communication in Healthcare. And they have many resources with COVID, and also with how to provide virtual care, virtual communication, and keep that humanistic aspects of medicine despite the distance, despite the screen. And so thank you, Dom, over to you now.
Thank you, Brigitte. So I was just to summarize this quickly about psychological safety, and I think we've illustrated, and many of you bring it up during our group discussion, how really at the core of favoring both cognitive and emotional engagement from our learner, creating circumstances where learners feel psychologically safe is really important, right? And so in the literature I found, so there's this actually very interesting a paper coming from clinical rheumatology of all places, but that actually summarized very well the concept and some important element of psychological safety, and remind us that this is a feeling of that one is comfortable expressing and being themselves and sharing concerns and mistakes without fear of embarrassment, ridicule, shame, or retribution. And there's another definition here that comes from interviews conducted with medical trainees, actually, about their perception of what psychological safety was. And there's the other reference here. But essentially, it's creating circumstances where people can really focus on the task and what they are learning rather than self. And it's kind of taking away this notions of, being self-conscious about what they're doing. And that is true actually in a virtual and a real life environment. It's not necessarily about being nice, although it helps probably, but it's a bit more than that, and in making sure that people are comfortable engaging, right? And that comes from pretty deep, right? As humans, we all tend to engage in behaviors that are preserving our ego and that are actually mitigating the risk, the personal risk that we perceive in our environment. So if we think by doing or saying something, we're going to expose ourselves to negative consequences, like, a demeaning remark or being belittled by our peers or worse, the supervisor, well, obviously we're going to engage a lot in impression management, right? And that means behaving in a certain ways that doesn't necessarily reflect what we think is the right thing. And that's kind of exacerbated in healthcare profession education because of our hierarchical structure and the fact that hand supervisors or teachers, we often also assess our future colleagues of our learners. So that create the perfect circumstances for people not to feel comfortable, and therefore we need to think actively about how to undo often years of kind of learning in environments that are not always optimal, and creating circumstances pretty quickly to make people feel comfortable. So as a facilitator, again, if you set goals that are clearly focused on learning rather than performance, if you find ways to invite people to participate in different ways and provide support when people do, and I will always remember having a session with a properly trained vital task, just witnessing or sitting in a session of a properly trained vital task instructor who was running a session with our trainees and you know, engaging in through positive feedback throughout the session. I didn't hear them say one thing negative about what the trainee did, even if at some point I was thinking, there's a bit of room for improvement there. And then, but this is one of their key teaching strategies, because even the perception of having some criticisms or you know, being feeling uncomfortable with the feedback provided can actually prevent people from engaging in that's really key, especially with communication skill training, right? So that doesn't mean being dishonest, quite the opposite. But that means that being careful in the way in which we do provide the feedback and using strategies focused on inquiries. So, you know, like, you know, ask them to explain why they did certain things a certain way. Don't make assumptions about the problem from the end of the learner, but ask them to be explicit. And then give them credit just for the participation itself, which is really often an act of courage in certain learning environment. There are other, you know, practical kind of advice that have been published more recently or less so in the literature. And this group in this reference here as another mnemonic, but center. So how to ensure confidentiality, equity in terms of airtime, non-judgmental listening, timeliness, and you can see the other things. So this is actually also a helpful resources. And essentially, if we think about virtual learning, there actually been a bit of a, it's viewed in the literature a bit as a double-edged sword. Like a lot of people think about the anonymity of being on the screen, and even if your name is there, there's create this sense of safety, and people can feel certainly more, you know, comfortable in those environments and show some candor or vulnerability as we discuss. And, you know, for people who have social anxiety and all that, I think it certainly can be a great help. But also, as we've seen with social media, some of the anonymity makes people, you know, forget about their inhibition and maybe sometimes be a little bit too blunt in their comments. So as a facilitator, obviously, it's something we need to monitor carefully. So I'm just going to pass on for the last few minutes the slide deck to Anne to discuss a little bit about curricular integration.
Thanks, Dominique. So, you know, virtual communication and virtual teaching have been around for a long time. These are not new, but certainly the pandemic has catapulted us into this new reality. And I think we all are pretty much in agreement that virtual teaching and virtual communication are here to stay. And so I think as educators, we need to know how to integrate these different goals and modalities into our programs. Next slide. So I think all of us are comfortable on that right-hand column of, you know, in-person simulation and in-person clinical teaching around communication. And of course, I'm just simplifying it as sort of these two areas, but there could be other areas that we teach communication in terms of having workshops and dialogues and that sort of thing, discussions. But this new column, I guess, or relatively new column for many of us is that virtual element of virtual simulation and virtual clinical teaching around communication. Next slide. So how do we really integrate simulation and clinical aspects into our communication training? I think this is not new for most of us here in the group. We've been thinking a lot about that previously in the in-person side. And so I don't think it's that much different for the virtual side, but there are maybe a few more considerations. You know, simulation is expensive, it's labor intensive. So thinking about where it's best positioned within our curriculum is really important. I really like this framework presented by Kiniara et al., who had sort of plotted acuity on that y-axis and opportunity on the x-axis. And, you know, simulation works really well when we are thinking about scenarios where there's high acuity and low opportunity, or for communication training, I would say it's probably high stakes and low opportunity, things that are rarely maybe done in clinical practice, but are certainly high stakes. And we could think of, I'm sure, many examples from our own fields. Of course, it can lead into some of the other areas in terms of that high stakes, but high opportunity, or sort of lower stakes, but things that just don't happen often. So that, of course, would be where I would say simulation works really well. Next slide, Dawn. But integrating the virtual and in-person might be a little bit more new for many of us. And I think if we're trying to find some guiding principles of how to integrate that into our existing communication curricula, we have to be thinking about our goals and objectives. So what elements of virtual communication are unique? What do we have to specifically be doing within a virtual environment, either through virtual simulation or virtual clinical teaching? What environment might be best suited for teaching one of these many competencies that Dom has put out in this flower here? For example, maybe emotions and responding to nonverbal cues is best in person. Or exchanging information maybe for efficiency, and given our current restrictions, it's best to do virtual. So taking these kinds of considerations into account as we plan the curriculum are going to be important. The level of the learner, of course, I think is important. We often think of simulation first before going into clinical practice, but the virtual environment might be a little bit more challenging. So we might want to give them opportunities to do that in person before moving on to virtual. Next slide. So if the goal is to teach our learners to be patient-centered and empathic communicators, then we really need to be teaching them to have dynamic, flexible, and adaptive approaches with the goal that we're reaching a shared understanding or common ground. And I think if we keep these sort of goals at the center of what our curriculum is, that will help us to determine what modalities and tools are going to work best. Next slide, Dawn. So I'm going to skip over this exercise because I think I've actually just passed time. Yeah. And I'm just going to wrap up on this last slide, which is really pulling it all together, right? And in this slide, you'll see some pros and cons of the different ways of teaching communication, both in the virtual and the in-person environment. I think that by thinking about virtual teaching and virtual communication, not as a replacement for the in-person, but rather as a complement or a way of augmenting what we're already doing is really important. The fact that we have to teach it explicitly rather than just assuming if we do the in-person or the virtual that the skills will apply in both environments, and then trying to balance between all of these types of modality, keeping in mind that particularly in the virtual environment, we have to consider cognitive engagement, emotions, and psychological safety. So thanks so much, everyone, for joining us this afternoon. I know that was a lot of information there at the end, but thank you for participating in the activities earlier on. And if you have any questions, please feel free to reach out to us via email.
Thank you.
Thank you, everybody.